So, this is one of the most popular but not so pleasing topics these days. One is cricket, second maybe doctors as well. And so, talking about cricket fever. So, if you go back, ladies and gentlemen, about 10 to 15 years ago, we had limited over cricket. And in which case, we had more sort of a defensive sort of approach. In the first 15 overs, the batsmen used to be more defensive, protecting their wicket. I would like to call this as a reactive sort of a strategy, because they will wait for the bad balls to come and they will score out of those. But however meticulous, however calculated risks that they took, but still they got clean bowled. But later, people revolutionized the game of cricket, and they took a more targeted approach. They targeted certain bowlers and tried to hit for sixes and boundaries. This I can call it as a more proactive sort of a way. We don't wait until the bad balls arrive, but we try to target certain people and score from the beginning. So dengue today is more about limited hours of overs. And we actually have a reactive sort of management strategy. We wait until the patient becomes hemodynamic unstable and we'll target our fluid management. So we take meticulous calculated fluid management and we take some risks as well. But despite, sometimes we get clean bowled. But do we have to change our strategy and thinking when it comes to dengue management? So dengue tomorrow, I think it should be more proactive, thinking out of the box. We should think beyond just normal saline fluid management, and we should be more target specific. So ladies and gentlemen, this is my topic today, light at the end of the tunnel, the vaccines and target therapy in dengue. So my goal is to critically appraise novel treatment modalities in dengue. And this is my outline, a snapshot on the epidemiology, about the novel treatment strategies, and something on the dengue vaccines, and how can we go beyond the light at the end of the tunnel. So dengue has been rampant throughout the world. More than 70% of the countries have been affected at the moment, and the case numbers are rising. When it comes to 2016 figures, it has been 2,500, the peak figure, and in the last year it was 10,500. So we are facing a great problem with dengue when it comes to numbers. And also it is becoming a more adult sort of disease. The children getting dengue is becoming lesser and lesser. And there has been a lot of changes in the serotypes happening, and also there's a global spread of the vector. But with all these changes, is there a change in the management? So, reactive sort of strategy is fluid management. We wait until something happens and we act. But more proactive sort of approach would be the controlling of the situation rather than responding to it after it has happened, which may be the future of dengue management. So, proactive mode of strategy, people initially thought, how can we manage dengue beyond fluids? So one person may have thought, okay, we will treat the dengue virus. So another person might think, why are we treating dengue virus? Which dengue fever is equal to another viral infection. So why don't we target the problematic area? How to stop the vascular leakage? Another person might have thought, okay, how can we prevent the disease of dengue by using certain strategies? So the first mode, treating the dengue virus, there are a lot of things that has been used already: antivirals, steroids, intravenous immunoglobulins, platelet transfusions, antioxidants, and further. There has been a number of antivirals which has been tested and tried. And first one is chloroquine, but unfortunately people have not found anything except for its antipyretic effects on dengue people. And people have tried balapiraviral and the antiviral used in Hep C, but unfortunately negative results. Again with Celsius vial, it has happened. But Cefalozavir is a drug which is promising. In certain subgroup of patients, they have seen some benefits of stopping leakage. So there is a trial which is ongoing at the moment in 2018. I think we have to eagerly wait for that. And also, although we stop statins in dengue, people have seen that lovastatin, a group of a drug in statin group, has some antiviral properties. It has endothelial stabilizing effects, same as the plaque stabilizing effects in atherosclerosis. So people have tried lovastatin as well, but negative results. But they say it's safe if the patient is on statins. It may be safe. It does not cause excessive hepatitis. Steroids has been used very frequently earlier, but unfortunately in Sri Lankan studies as well as systematic reviews, there has been negative results. Immunoglobulins, people have thought that dengue is acting as safe as ITP or immune thrombocytic purpura by producing certain autoantibodies against platelets. But they have found autoantibodies, but when they are treating with immunoglobulin or steroids, they did not get any positive results out of it. And platelet transfusions has been harmful. Basically, it has increased the number of days the patient staying in the hospital. So again, negative trials, ladies and gentlemen. Antioxidants is the same. Papaya leaf has been very discussed among the general population as well, but there have been several good, well-conducted Indian trials, and they have the patent for the Areca papaya tablet as well, and they have done RCTs for papaya leaf extracts, but unfortunately it has been negative. But in day 7 or day 8, there has been some improvement in platelet counts when you use papaya. But ladies and gentlemen, you know that at day 7 and day 8, if the patient, most of the patients are at home. So, because of these negative trials, people have thought, why are we only targeting on the dengue virus? Can't we think beyond and go to target leakage? Because that is the problematic area. Those are the patients who die. So, people have found there are mediators of vascular leakage. Some potentiate or increase the vascular permeability. Some actually protect the endothelial barrier and stop vascular leakage. So these are certain things I want to discuss today. So vascular endothelial growth factor, platelet activating factor or PAF, which I am going to discuss today. And there are other mediators which increase the vascular permeability. People have initially studied allergy and anaphylaxis, in which case there is increased vascular permeability, and they have checked the same of these mediators in dengue as well. So they have found, okay, same things are elevated in dengue as well, as it increases the vascular permeability. And other two interesting factors are the sphingosine 1-phosphate, which is a phospholipid, which prevents vascular leakage and holds that integrity and prevents leakage of fluid into the body cavities. So, ladies and gentlemen, one of the mediators of vascular leakage is PAF, or platelet activating factor, and this is found to be increased in dengue fever and more in patients who are having dengue hemorrhagic fever. So people have thought, why not we target PAF as a treatment for dengue hemorrhagic fever? So rupatadine, same as the same group as the drugs called loratadine that we all use for cold and upper respiratory tract infections. So rupatadine has antihistamine activities, as also it reduces PAF, a mediator which mediates vascular leakage. They have done a preliminary study and has found that this is the efficacy and safety trial which they have published, but in which case they have used small numbers because it's a safety and efficacy trial. But unfortunately, they have not seen any significant reduction in fluid leakage, which has been observed. But the limitation is they have used very small numbers to this study. But they are used a randomized control trial, they have been studying. But in the post-hoc analysis, they have seen that there's a trend that people have got small effusions when it comes to dengue hemorrhagic fever. The sphingosine 1-phosphate, or S1P, is another factor which holds the integrity of vascular endothelium, preventing leakage. And there has been some studies of sphingosine 1-phosphate, and they have found that in dengue hemorrhagic fever patients, the S1P levels are low. So this is another target that if the people can provide S1P to patients with dengue hemorrhagic fever, whether we can stop leakage. We have to wait for that. And also, the commonly used NS1 antigen to check the diagnosis of dengue, people have investigated whether we can produce the vaccination for NS1 antigen and reduce the vascular leakage from that, because they have found that NS1 antigen is a potential mediator of vascular leakage. And currently there has been mice studies and there are promising results out of it, but we have to wait until human trials come out. So currently there has been not much of hope. Rupatadine cell gosipaya has some hope, but other therapies, there's a big question mark. Vaccines, ladies and gentlemen, is a very interesting and a topic on the last few years. So, if I go back to the details, dengue has 4 serotypes, and the most problematic point in preventing us devising a vaccine is they have 4 serotypes. Because when you have 4 serotypes, you need 4 types of antibodies, and that vaccine should be able to produce antigenicity to produce 4 types of antibodies. But the problem is with dengue is what you all know is antibody dependent enhancement. When you are having a pre-existing antibodies, it potentiates the severity, and when you get dengue to the second time, you get worse disease, you get severe disease. So the main problem is vaccine enhanced disease, and I will explain this to you. So if a person gets primary infection, so they develop antibodies, and after some time they will get a secondary infection, and naturally this is the most severe type of dengue. What happens if you vaccinate them? So when you vaccinate a person, they develop antibodies, and when they get the dengue, actual dengue, that acts as the second, and although it's the first episode of dengue, but they are already having antibodies, that they act as sort of a secondary dengue. Because of that, when you immunize a patient who has not had dengue before, when you actually get dengue for the first time in their life, they get severe disease. So that vaccine has enhanced the patient to go to a severe form of a dengue. This is the dreaded complication of giving the dengue vaccine to people who has not been immunized earlier. But think, if they have already got the secondary primary infection from the natural way, and you vaccinate that patient, and when you vaccinate, you don't actually get the disease, but you get immunized. So that is technically the secondary dengue that they got. So when you actually get dengue for the 3rd time and 4th time, the quaternary and tertiary dengue, so that is again becomes a milder disease. So I think this is the most important strategy that we must use when it comes to dengue vaccination in dengue. So there are 5 vaccines in trial at the moment. So first one is Dengvaxia, second one is Tapida vaccine. Dengvaxia became very famous in 2015, and it was approved in 2015, discovered by Sanofi, and it covers all 4 serotypes and is made on the yellow fever backbone, and we have to give 3 injections, and when it is registered in 19 countries, it became very famous. And these are the 2 landmark trials that they have used. They have used a South American sort of a cohort and an Asian cohort. So when you actually look at just superficially on that, the Dengvaxia, you will see, if you see these Kaplan-Meier curves, you will see that in the vaccination group, the cumulative incidence of cases is less. So simply if you look at this, you will say, okay, Dengvaxia is really good. It reduces the amount of dengue that the patient is having. But when you really dig deep into the data, you will see some pitfalls. So if you see here, people who are seropositive, they has a good efficacy. As I explained to you earlier, people who have got dengue before, when you immunize it, it has a good efficacy in giving protection in dengue. But the problem comes when the people are seronegative. The efficacy of administering vaccine to seronegative people is not that good. It's 50%. It's not adequate at all. And when it comes to dengue 2 virus, which is the last reason for the outbreak at the last year, which we had thousands and thousands of cases, it does not give protection for that. So ladies and gentlemen, it seems not effective. And because of that, the WHO said, okay, you have to use the dengue vaccine when there's a high seroprevalence in countries. High seroprevalence. But in Sri Lanka, even in Colombo, the seroprevalence is not higher than 70%. That is the problem. And if you look at carefully on this table, at 2 to 5 years group, if you see the vaccine related cases, that's 56, and in the control group where they have not received the vaccine, it's 23. You will see the vaccine group has more number of patients having dengue. Same when it comes to 6 to 8 years age, same 9 to 11 years of age. So in this group, vaccinated people have more disease. So which is very questionable. Why should you give a vaccine and induce dengue? But when it comes to the 12 to 16 years of age, the controls, there is less number of cases in the vaccine. This may be due to the reason that these age group people might have already got dengue before. That is the explanation. So the necessity for the vaccination still remains. There are pitfalls. You need 3 vaccinations. You have to spend more and more money and poor immunogenicity. And there's a vaccine-enhanced disease which increases the hospitalization of dengue. And there is no data on dengue hemorrhagic fever, which is the main failure that dengue vaccine has faced. Because we have to concentrate on people having dengue hemorrhagic fever. And also, is it a good vaccine? We have to look at the number needed to vaccinate when we are deciding whether it is a good vaccine or not. So, number needed to vaccinate is, if you look at this table, for all dengue in Asia Pacific is 1828. To prevent one hospital admission of severe dengue, you have to vaccinate 75 or 201 patients in different settings. So, which is a big number. And so in this situation, I would prepare to buy dengue vaccine if it is sold for 35,000, 10,000, 3,000. So what about giving for free? So Philippines is like one country that they have accepted this vaccine, but they have faced problem. They have seen that people are having more and more dengue. So the lawyers have gone to court and they chased off Sanofi from their country, and they have not given the dengue vaccine anymore. And if you see this, their vaccination schedule has totally gone into failure because they are not getting the dengue vaccine now, and because of that, the patient has refused getting polio vaccine, diphtheria vaccine, everything has gone into utter failure. So rightly so, Sri Lanka, which is one thing that we can happy about Sri Lanka, they have taken a decision, okay, no, we are not importing dengue vaccine for the moment, which is good. So because of that, WHO has recommended saying that vaccination with dengue vaccine should be only done if there is a proven past infection of dengue, which is a good thing to discuss. So then comes the dengue vaccine or the Takeda vaccine, which is the part of Sri Lanka is also involved for this Takeda vaccine, which is built on the backbone of dengue 2 virus. So expecting that dengue 2 virus will have good safety when you give Takeda vaccine, and more than 2,000 patients already vaccinated in Sri Lanka in 5 centers as well. So we have Sri Lankan data very specific for this vaccination, which is really good, because we are always trying to implement Western recommendations to our setting. So if you take the immunogenicity in the phase 2 trials, they have shown that there is good immunogenicity in all groups. And if you look at this table, the safety and efficacy data, there are 4 groups that they have vaccinated. The 4th group is the placebo group, in which you will see 4.5% of people have got dengue, but in all the other 4 categories, 1.6, 2, 0.7, 1.4, so all the people have used different vaccination schedules, but there has been good amount of safety, and we can see efficacy as well, but in a smaller amount of people. So we have to wait until the phase 3 data is available. And there are other 3 vaccines as well, such as NIH vaccine, recombinant V180, inactivated vaccines and all that. So it is currently in trials at the moment. So ladies and gentlemen, what is the way out of this tunnel? So we don't have drugs, we don't have a good vaccine at the moment, we have to wait for everything. So what is the way out of this tunnel? Is to combine everything. Vector control, vaccination, clinical care, fluid management. We have to think as a whole still. We don't have a magic drug at the moment. I'm sorry to disappoint you with that. So we are thinking that we have reached the light at the end of the tunnel, but when you go out, you will see that there's a long distance to go. So we have to wait patiently. So summary is the dengue is a global burden which is still rising. There is some hope for certain antivirals and therapy targeting linkage. Those are very promising investigations going on. Vaccines need stringent surveillance and you need to decide on it. You have to commit on it after having a good discussion with all the authorities. And there are efficacy and cost-effective issues, and it's always, we have to be proactive. We have to move from being reactive to be more proactive someday, because we cannot always rely on the fluids. So take home message, all the time we have relied on fluids, but now we are thinking of a revolutionized treatment, and we have to think about the light at the end of the tunnel. So I would like to acknowledge the Department of Medicine, or the professors and the lecturers out there, and they have provided me a second home, which I am most happy to thank to them. And also Professor Malavike and Dr. Lakmal Fonseka, who has been 2 dengue authorities in the country, who have shared some of their data with me, and also, most important, my family, my mother and Dayashi, and then my family and friends, who has been always be there for me. Thank you very much.
Congratulations, Lakmal, for winning the competition, and mostly for the analysis of wonderful proactive approach for dengue. I invite President of the World Association of Fonseka to present the winning gift and the certificate.